We will start with the general organization of the urinary system. So the urinary system is composed of a two bean-shaped structure present on the posterior abdominal wall. If we remove the GIT from the abdominal wall after opening the anterior abdominal wall and remove all the GIT and the mesenteries, we will find these two structures bean shaped lying posterior to the abdominal wall. Then we have an excretory passage starts within the kidney called as major and minor calyxes, and then they come out as a ureter, and then ureter go down in the pelvis and opens into the upper lateral part of the urinary bladder, and from urinary bladder urethra is coming out, which is the exit passage of the urine. So these are the two main structures responsible for. So kidney, they are positioned in the posterior abdominal wall, and you know why they are positioned and how they are positioned. We will discuss it later on. Why they are not. So each kidney is approximately having 1.3 million nephron, and daily, every day, blood which circulates within the kidney will form about the filtrate is running about 1700 ml of the filter. What it do? It removes the toxin product of the metabolism as the urine. It conserves the salt which comes out from the filter. It consumes water, definitely. Filter comes out water and then again have been absorbed back. It resorbs glucose and protein. This is all physiology from the urinary structure called as nephron. And you will be having different lectures regarding this system and the function in the physiology. It also regulates blood pressure, hemodynamic, and acid base balance, which is the base of this course. So you have to go through acid base balance and regulation of the blood pressure and hemodynamics of this function of the kidney. It also produces some endocrine hormones, renin, erythropoietin, and prostaglandins. So this all belongs to physiology, and you will do in your physiology lectures. Now coming to the kidney. Now, as I've told you, you can see the kidneys are lying in the posterior abdominal wall, in front of this posterior abdominal wall, and they are retroperitoneal structure. I hope you all know that what does the retroperitoneal structure means. It means the structure which are behind the peritoneum, or the peritoneum cover only on its anterior surface. Usually, the other name of the kidney is nephros. Okay, so we will call the kidney as nephritic or nephron. Nephron is the functional portion of the kidney, so we can uh, manage to write in clinical terms anything related to nephron means related to the kidney. Each kidney lies on the posterior border and it is lying on lateral to the vertebral column. Now here you can see this is inferior vena cava and aorta. They are lying just anterior to vertebral column. So it is lying in the lateral to the vertebral column. And you can see if we extend kidney from up to down, it usually starts from the T12 level and it ends at the level middle of the lumbar 3 vertebrae. So this is the extension of the kidney, T12 up to in the vertical direction. You can see in this diagram, this left kidney is lower as compared to the right kidney. Why? Because we have a large liver at this space. Large liver. Due to the weight of the liver, the right kidney is at the slightly lower level as compared to the left kidney. Usually, what we see in the surface anatomy, we differentiate the organs in different quadrants or different regions. So if we compare this kidney, usually kidney lies in the epigastric region, right and left this hypochondric region, lumbar region, and the umbilical region. So its majority, we if we talk about both kidneys, hypogastric region, hypochondric region, epigastric region, umbilical region, and right and left lumbar region. Low, if you see again in the position, the right kidney is nearer to the midline as compared to this left kidney. It is away from the kidney. So this right kidney and left kidney is related to the midline. Right is nearer to the midline as compared to the left one. So in the left one, this will be easy if anybody needs a kidney or if anybody donates the kidney. The left one is more easier to take out as compared to the right one. So this is the clinical important. The left kidney is more easier to take out for the renal transplant. Now, this contraction of the diaphragm, every respiration, definitely here lies the liver and here lies the stomach and spleen. This contraction of diaphragm lower, it is going to slightly move the kidneys downward. Okay, not as the lungs are expanding and recoiling. This diaphragm press the kidneys because of the pressure of the liver and stomach and all over there. Slight movement occur in the kidney in vertical downward direction. Now let us see the color and the shape. It is reddish brown in color. You can see kidneys are reddish brown and bean shaped structure. The dimensions are each kidney is about 11 centimeter long, 6 centimeter wide, and 3 centimeter thick. Okay, so you have to remember these measurements. Although they are smaller in size and shape, the left kidney is slightly longer and more cylinder than the right kidney and nearer to the midline. So the right kidney is nearer to the midline. Now, if you see, this is the lateral border of the kidney, and this is the medial border of the kidney. Now, if you see geometrically, this is convex border, which is the lateral border, and the concave border, which is the medial. And if we more particular see, kidney as it is a vertical structure, it has an upper pole, and kidney has a lower pole. And if we compare upper pole and lower, they both are also convex in nature. So the lateral border is convex, the lower pole is convex, the upper pole is convex, and the medial border is concave. Okay, so if you see this medial border, the both part of the medial border shows this depression. Can you see? We can see this medial border is showing uh, a depression. We call it as hilum. We call it as hilum. Let us see other picture. Here you can see the upper pole, the lower or inferior pole, the lateral margin or the lateral border, and the medial border, which is having a depression from which these structures are entering and leaving the kidney. This area is called as hilum of the, as you compare in the lungs, there were hilum of the lung or root of the lung from which structures are entering and leaving. Upper pole of each kidney, right or left, it is having this endocrine gland which is called as suprarenal gland. Inshallah, in MD2, when you do endocrine system, you will go into detail of this gland, endocrine gland, suprarenal gland. Now the hilum. The hilum transmits, definitely, if this is hilum, it transmits the structures. Can you see? So if we compare from anterior to posterior, the structure which are entering or leaving, first one is the renal vein, then the renal artery, and lastly, posteriorly is the ureter. So this is the ureter, then this is the vein artery, and this anteriorly is the vein. Let us go back. Here you can see the vein, then the artery, and the most posterior structure having good downward extension as ureter is the renal pelvis and ureter. You have to remember this arrangement. Then renal sinus contains the upper expanded part of the ureter called as renal pelvis. So if we go deeper, which we see this extended portion of the ureter, upper expanded part, this is called renal pelvis, and it is the excretory passage from the kidney. So this is present lying within this deep structure of the kidney called as renal sinus. And this pelvis is surrounded by, and these structures which are entering and leaving, surrounded by this fat. Can you see this yellow structure? This is the fat, and it is called as perinephric fat. Again, the word nephric is for kidney. So perinephric fat is continuous into the hilum because it is surrounding the kidney. From the hilum, it is entering inside into the renal sinus. So in the sinus and surround all the structure which are entering and leaving. Now, the most important part of this lecture is the covering. You know, covering, kidney is covered by, and this covering is the most important part of the position of the kidney. Now, kidney is lying in the posterior abdominal wall, but it is not attached with any of the muscle. Okay, or nor you can see it has a ligamentum support, but the kidney is lying in its position in the posterior abdominal wall. How? Number one, it is attached to the aorta and inferior vena cava through the renal artery and vein. But the most dynamic support is the fascia which is covering it. And these fascia which is covering and holding it, it is the main reason the kidney is in position at the posterior abdominal wall. First, its own fascia with the fat, then the fascia, then again a fatty layer which keeps it in the posterior abdominal wall. You know, people start to a diet program, and the diet program they lose quickly the fat. So, the quickly losing the fat may disturb the position of the kidney. So, if you start a dieting plan, you have to maintain it and go slowly. So, first covering, you can see if we come out from inside to outside, this is the capsule, which is the small layer closely adherent to its surface. Okay, so this is the fibrous capsule. It is a thin membrane which closely invests or cover the kidney and lines the renal sinus as well. Normally, it can easily be peeled off. Then, the second is the perirenal fat, which covers the fibrous capsule. The first layer after the capsule will be the fat, which is called as perirenal or perinephric fat. This is the layer of the adipose tissue lying outside the fibrous capsule, and it is the thickest at the border of the kidney and fills up the extra space within the sinus. Extra space within the sinus will be filled up with this first layer of the fat. Then we have another layer of the fascia. Can you see this gray line? this gray line outside this fat, this is called as renal fascia. This is the condensation of areolar connective tissue that lies outside the perirenal fat and encloses the kidney and the suprarenal gland. If we see, here lies the suprarenal gland. This condensation of the renal fascia go, splits and cover the suprarenal gland, which is here, and continue with the diaphragm. This fascia upside continues with the diaphragm. Superiorly, it surrounds the two layer which is going towards the diaphragm. And then if we see medially it is continue with the other side fascia on the anterior surface of the blood vessels, aorta and inferior vena cava. And behind it continue with the layer which continue on the other side with the aorta and the muscles of the posterior abdomen. Laterally, you can see this anterior layer of renal fascia and posterior, they combine and laterally it continue with the fascia transversalis. If you remember, there were three muscle of abdominal wall: external oblique, internal oblique, and the transverse abdominis. And we were having a fascia transversalis, which is on the anterior aspect of the inner side of the transverse abdominis. So this layer, renal fascia, laterally continues. So you can see this is also a big support for kidney in their position. Then outside we will be having para, which is surrounding pararenal fat, lies external to the renal fascia and is part of the retroperitoneal, because here you can see this is the peritoneal cavity and this is the outside, so we can call this as pararenal fat. The last three structures support the kidney and hold it in the position on the posterior abdominal wall. So hope you remember fibrous capsule, perirenal fat, then renal fascia, and then pararenal fat. Now the relations. Quickly we'll go through the relations. Now here you can see kidneys lying in the posterior abdominal wall, here and here. In this diagram you can see they have removed the liver over here, they've removed the stomach over here, spleen over here, and then the majority of the ileum, colon, they have removed. Just what is lying, you will see this is the duodenum and this is the pancreas. Clear? Now keep this in mind. We'll see the anterior face of the both kidneys are related to the numerous structures which are invested. What is these yellow structure? This is peritoneum. This is the left behind peritoneum. Otherwise, this lies directly against the kidney without the peritoneum. Let's see. The left kidney. Okay. The left kidney, as it is a retroperitoneal, only slight area is covered by peritoneum, like this and this. So if we come from above to down, the superior pole along with the medial border is covered by suprarenal gland. Then we can see this portion of the kidney anteriorly related to stomach spleen because it is on the left side. Then we can see the tail of the pancreas going towards the spleen over here. So it is also crossing over in front of kidney left. Then we have the descending colon and left colic flexure, which is the splenic flexure. It is going, and the small intestine portion called as jejunum in the lower part. So this is the relation of the left kidney in this part. Now see the right kidney. Right kidney again anteriorly in the upper part we will be having the right suprarenal gland. Then we have a majority, a big portion related to the liver, and the liver peritoneum is completely covering except its bare area, but the reflection from kidneys goes to the liver. Then this hilum area or the medial border, it is related to the descending part of the duodenum. or you can say its second part of the duodenum is related to it. Then we'll be having the right colic flexure, which is also called a hepatic flexure, the right colon, and again the small intestine mesentery loop we are going to have. The lower part is directly related to right colic flexure, and on its lower medial side related to intraperitoneal small intestine. So you can see these are this. Now here in this diagram we have compared that anterior. So you can recall your memory by this slide. Right kidney above suprarenal, left kidney above again suprarenal. Then the right kidney is having liver, and in left stomach and spleen. Hilum, second part of duodenum. In the left we have pancreas. Here duodenum, here pancreas. Below is the right colic flexure and jejunum, and here left colic flexure and the jejunum. So here you can see the in one slide you can compare between the anterior relation of the kidneys. The posterior relation, very important part. You will be having the seminar on the posterior abdominal wall, in which you will have to describe these all structure present in the posterior abdominal wall. But the kidney, all the structure of posterior abdominal wall are same on both sides, except one. Let us see. Diaphragm, definitely. It is lying on the region of diaphragm, which is the crura. So they are lying behind the kidney. So both side, both kidney have diaphragm. Then above diaphragm, costodiaphragmatic recess of the pleura. Okay, done. These two structures are same. Then left kidney, we will be having 11th and 12th rib on the posterior at the last intercostal space. But on the right side, 12th rib only, and the last intercostal slightly space. Why? You have just discussed that right kidney is at the lower part than the left kidney. Okay, so the left kidney will be having both ribs, 11th and 12th, but the right kidney will be having only the 12th rib. So this is only the difference between the posterior relation of the right and left. Otherwise, other structures are the same. Psoas major muscle, quadratus lumborum muscle, these are the muscles of the posterior abdominal wall. Transverse abdominis, subcostal nerve, iliohypogastric, ilioinguinal, the L1 nerves, iliohypogastric and L1 nerve. So only and only difference is the 11th and 12th rib on the left kidney and the 12th rib only on the right. The rest both are same. So please remember for the MCQ point of view. Here you can see from behind, this is the 11th rib and this is the 12th rib. So this is the left kidney and this is the right kidney. So here you can see only and only 12th rib and a small part of the 12th intercostal space. Then here you can see this is the diaphragmatic portion. Then you can see this is the psoas major muscle portion. Then lateral as we go is the quadratus lumborum and then transverse abdominal muscle. So this is the posterior relation. And definitely you can see here will be lying the subcostal nerve. Then from L1, iliohypogastric and ilioinguinal nerve crosses from this area. These are the two important angles present are formed on the posterior aspect by which we can proceed towards the kidney or from the posterior thoracic wall on the lower part of the posterior thoracic. There are two angles formed over here. One angle which is called as vertebrocostal angle. It is found by the vertebral column and the last rib. Can you see? This is the last 12th rib and the vertebral column. Part of the pleural sac is lying above it, and you can have this kidney directly approaching. After removing the muscles, we can approach to the kidney. And here you can see there is a renal angle. And this renal angle is formed by the lower body of the 12th rib. And there is a muscle. You can see this outline of the muscle is given in this diagram. This muscle, and this muscle is called erector spinae muscle. This is called as renal angle. So kidney can be palpated in these two angles. Oh, remember the angle how they are made. Now coming to the internal structure. Internal structure of the kidney. If we see the internal structure of the kidney with our naked eye examination, if we do a coronal section, this is the coronal section of the kidney. The outer reddish part is called as cortex. The outer reddish part is inner pale part is called as medulla. What it is? It is a medulla. And then in the medulla we have a space of this renal sinus in which these structures are entered. So this is cortex and this is medulla. The renal cortex is continuous band of the pale tissue surrounds the renal medulla. Extension of the renal cortex into the medulla. Extension of the cortex into the medulla, it is called renal columns. What they are called? Renal columns. The inner aspect of the kidney dividing the renal medulla into discontinuous aggregation of triangular. Can you see? This is medulla having a triangular shaped tissue. 1, 2, 3, 4, 5, 6, 7, 8, 15 to 20 triangular renal pyramid. What they are called? They are called as renal pyramid. Again, you can see this is the cortex area, and the portion of cortex which run into the medulla. Can you see this line showing by the pointer? They are called as renal column. Okay, and in the medulla we have a triangular structure. This is called renal pyramid. 1, 2, 3, 4, 5, as it is. These are called renal. So each renal pyramid is having a base which is toward the cortex. Can you see? This is the base having towards the cortex. And it has an apex which runs towards the medial side. This is called as renal papilla. And it is towards the renal sinus. And base is towards the renal cortex. Each renal pyramid project inwards through the renal papilla into the minor calyces. Can you see? The apical portion renal papilla is surrounded by minor calyces, which is the receiving part of the urine, okay, or the first part of excretory portion of the urine. This is the first part called as minor calyx. In the renal sinus, several minor calyxes, one, two, three, combine to form a big major calyces. So here you can see these are minor calyces. Again, another minor calyces. They are forming the major calyx. And three or four major calyxes combine to form this upper dilated portion called as renal pelvis, which is a funnel shaped structure, or you can say it is the superior and expanded end of the ureter. So, downward, can you hear me? I don't know why the system stops. Okay, let me jump to the slide. Okay, so we were here. We were here. Can you see the screen now? Okay, so all of a sudden it goes. Now, the renal papilla in the renal sinus. Okay, again you can see this is the renal cortex. In between the renal pyramid, this is going the renal columns, and here are the, and this is the base, and this is the apex of the renal pyramid, and open into minor calyces, then major calyces, the renal pelvis, and the ureter. Now the most important again part is the arterial supply. You can see the renal artery is entering from the aorta towards the renal hilum. But before entering of the hilum, the renal artery divides. Okay, the question comes: what is the difference between the renal sinus and the renal hilum? Sorry, the renal pelvis. Actually, renal pelvis is the upper expanded part of the ureter, and it is present inside the kidney. And from where it comes out from the renal sinus. And what is the renal sinus? It is the depressed portion of the renal hilum. So hilum is the portion from which the structure are entering and leaving. If we see deep into the hilum, we will find a renal sinus. And in renal sinus, we are having the fat and the renal pelvis, which is the part of ureter. Hope you get my answer. Each renal artery, each renal artery divides into five segmental arteries. You can see one, two, three, four, five. These are the five. Okay, okay. Oh, because the screen went out. So this is the renal artery, and you can see this is segmental branches. Four segmental arteries are and entering, and one artery lies behind the ureter. Can you see? This is the pelvis. One is lying behind, and four are lying. So these five segmental arteries are entering into the renal structure. Now be with me and see how it enters and comes out as the renal vein. Each renal artery divided into five segmental, four in front of the renal pelvis and one behind. Because renal vein is the most anterior structure in this hilum. They are distributed into different segments of the kidney. In the end, I will discuss about the segment, how many segments. Each segment artery gives rise to number of lobar arteries. Can you see? These are the segment, and we are having this lobar arteries. Can you see? These are the lobar arteries. Now, why we call? Because if we compare this a pyramid and this is the cortex, this is the one structure unit of the kidney. We can say you can call it as a lobe of the kidney. Can you see? The this cortex and the pyramid along this portion is called one lobe of the kidney, another lobe of the kidney, another lobe of the kidney. So this artery which is going, it is called as lobar artery, which supplies the pyramid. Now let us see where it goes. So here segmental, then segmental is forming the lobar artery which goes towards the pyramids. Can you see? Now, when reaching to the pyramids, they are called as interlobular arteries. Okay, interlobar arteries. Now, run towards the cortex on each side of the renal pyramid. This is called as interlobar arteries. Interlobar artery. At the junction of the cortex of the medulla, the interlobar arteries, these arteries, which are the interlobar arteries, they turn towards the base of the pyramid. Each pyramid, can you see? They are turning to the base. They are turning towards the base of the pyramid, and this base of the pyramid, they changed their name and called as arcuate arteries. What they are called? They are called arcuate arteries, which arches over the base of the pyramid. Now, if you see this diagram, you can see this each arcuate artery is also again giving these small tiny arteries. Can you see? These arteries are going towards the parts of the lobule, and we call it as interlobular arteries. The arcuate arteries give off several interlobular arteries. Can you see? They are running in the cortex. They are running several interlobular. So first one, the renal, then the segments. After segments, interlobar arteries. Interlobar arteries give arcuate arteries, and arcuate arteries give interlobular arteries. So it ascends in the cortex and give off afferent glomerular arteries. We know that functional unit of kidney is called as nephron. Okay, here you can see the pyramid: renal, segmental, interlobar, arcuate, interlobular. Now comes the afferent arteriole. Here you can see this is the arcuate artery. Arcuate artery gives interlobular, and interlobular is giving the afferent arteriole. And this afferent arteriole is going to form the glomerulus, which is the tuft of the capillaries in the nephron. Inshallah, in your histology lecture, you will be having detail of this nephron structures and this barrier and filtration structure. Then you can see again, this is not after glomerulus, it is the vein. It is again an artery. It is called this efferent arterioles. And this efferent arteriole will cover the tubules of the nephron like this. Can you see? It is covering the tubules of the nephron. And then from there, peritubular capillary networks are formed. And from there, vasa recta will be formed. The straight veins, can you see? Straight arteries, then straight veins. And then they come out as arcuate vein, then interlobular veins, arcuate veins, then will interlobar veins, can you see? And the interlobar vein combines to form this renal vein. Can you see? So the venous drainage occurs over here. The previous slides, if we see, again no pointer, I don't know. Here again it goes. So here you can see interlobular. I'm just going to this. Now, see, abdominal aorta gives renal artery, then segmental arteries, then lobar, interlobar, arcuate, interlobular, afferent arterioles. Then goes to the afferent glomerulus, then efferent, vasa recta, and all, then arcuate veins, interlobar veins, renal veins, and inferior vena cava. So let us move quickly because I think you will be having it. Now we were talking about the segments of the arteries. Four comes in front and one goes behind the pelvis, the fifth one. So fifth one definitely goes to posterior side and supply this posterior. So we can call the fifth branch which is running behind the pelvis, it is the posterior segment, supplying the posterior segment. The first one is the apical segment. Then we will be having the three, two, three, four, like this. They are having the names of the part of the kidney supplying. One is the anterior superior, anterior inferior, and the caudal, the tail. So, how many segments of the kidney divided according to the blood supply are the apical, the caudal, the anterior superior, anterior inferior, and one posterior. These are the segments of the kidney. Clinical importance, we'll see. Venous drainage, I have just discussed with the both renal veins. Can you see? These are the renal veins. This is the renal vein. This is the inferior vena cava. Both renal veins drain into the inferior vena cava. Left renal vein is longer 3 times as compared to, because it is nearer to the vena cava, and here it has to cross all the way long, cross the aorta, and then enters. So for this reason, the left kidney is preferred the side of liver, live donor of the kidney for the nephrectomy. The right and left renal vein runs from its origin to the renal hilum, anterior to the aorta and posterior to. Now this is the aorta, anterior to aorta, and this is the superior mesenteric artery. So behind the superior mesenteric artery runs the renal vein, and posterior to the mesentery, here lies the mesentery of this small intestine. This is the level of the mesentery of small. So it is also. Now, if you see anteriorly, it is having superior mesenteric artery. Posteriorly, it is aorta. So aneurysm of the aorta, the dilatation of the aorta in any disease can compress the renal vein. This is the main point to remember over here. Lymphatic drainage, as it is nearer to the abdominal aorta, there are para-aortic or lateral aortic lymph nodes which helps in the drainage of the kidney. Then coming to the nerve supply is the renal sympathetic plexus. Okay, and the afferent fibers that travels through the renal plexus enter the spinal cord, level 10th, 11th, 12th thoracic nerve. So what are these? They are only for the controlling of the vasodilation or the uh, blood supply control. Again, you can see this is a complicated picture, but not complicated. Let us see. This is the left kidney, right kidney. This is inferior vena cava. This is aorta. Here you can see this is the left renal vein, longer as compared to the right renal vein. Here, the left renal vein behind is the aorta, and anteriorly this is superior mesenteric artery. One thing more, the right renal vein does not have any tributary, but the left renal vein has this left testicular vein or left ovarian vein entering into the left renal. So this you remember that the left renal vein have the left ovarian or testicular vein draining. And another tributary is the inferior suprarenal vein. Suprarenal vein also draining into the left renal vein. Now, definitely after physiology, you will be having pathology, and sometime you can see the kidney changes in disease pattern showing like this. Kidney will be having these small cysts. Sometimes, definitely, what is the function of the kidney? To filter the blood. Some may be parasites, or some may be disease particles can enter into the substance of the kidney. They can cause damage to the kidney. Sometimes inflammation of the kidney will call as glomerulonephritis, which is the most important disease of the kidney, and pathology will lead. And then you can see multiple cyst. It is called poly, means multiple cystic disease. Here you can see the polycystic kidney disease you will be having in pathology. Then ureter, which is the structure carry out the urine from the kidney. Sometimes stone formation can block the ureter, and the urine which is forming in the kidney comes out, but it does not have the outer passage, make the dilatation of the ureter, and that is called as hydronephrosis. So this dilatation also goes into the kidney, and it may increase the size of the kidney. It is called hydronephrosis. So we have to clear the obstruction so the passage of the urine goes out. So you will be dealing this in the pathology. Again, you can see this is the transverse section of the kidney showing these renal pyramids and showing this cortex of the kidney. This is the renal pelvis, and you can see a small stone in the renal pelvis. So stone formation, because salts and oxalate crystals, they also comes and accumulate in the kidney structure. So they will form these small stones in the kidney. Multiple stones in the kidney, can large and a small stone. So you will be having this also in your pathology lecture. I thank you all to be with me in this lecture. Hope you have gone through the main structure and the histological structure, inshallah, you will do in your histology lecture by Dr. Ala. So I suggest you all to focus on your physiology in this course. Physiology and pathology are the main backbone of this course. Any question, you are welcome. You are welcome. And inshallah, I pray you all go into MD2 and clear these courses. Uh, we'll see you next year, because will be my last lecture with you. Maybe Dr. Valla will take your urinary bladder at 11 o'clock. Any question? Any question from this? And hope in this limited sources you have uh, know little bit about the kidney from me. Any question you can ask anytime. Question at my email. This is my email, and you can ask question if you have anytime. Thank you, Jazakallah. Doctor of Physiology will, inshallah, be there to start the next section.